Dear friends, welcome to the Indian Academy of Echo webinar sessions, which is a great initiative which has been undertaken by IAE. And today we have a very interesting session on mitral stenosis, where we will cover most of the basics as well as advanced aspects of mitral stenosis. I am Dr. Vinayak Agarwal. I am Director and Head of Clinical Cardiology and Non-Invasive Cardiology at PSRI Hospital, Saket in Delhi. And I'll be moderating this session. With me is a very accomplished and a very good speaker, Dr. Shantanu Sengupta, who needs no introduction. He is one of the leading cardiologists at Nagpur. He is actively involved in IAA activities in so many echo conferences in national and international level. Very avid researcher, has a lot of original papers in leading research journals. And I'm very happy to actually have him take this extremely important topic of mitral stenosis. It may sound very simple, but it has a lot of nuances. And some of his seminal work, which he's done in the field of mitral stenosis, also he would be touching upon. So I invite Dr. Shantanu to begin his lecture, and we will take up the questions at the end of the session.
Great. Thank you, Vinayak. I hope I'm audible. It's indeed a pleasure, and thank you so much, Ai, for this opportunity. I think mitral stenosis has been our bread and butter, but there are a lot of things which have come up recently, and I'm extremely thankful that I can share up my views. And it is not going to be a very lengthy session, so I'm going to start sharing my presentation. And what is today's aim is that the address is for both beginners and also an advanced people who like to do an echo imaging, both basic and advanced. So we have titled this as Comprehensive Assessment of Mitral Stenosis, Troubleshooting in Assessment and Solutions. Well, why exactly we need to do an echo? What we need to do an echo in mitral stenosis should be known. That we have to first confirm that there is a lesion. What exactly is the cause of lesion? We have to understand what is the etiology, what is the severity, whether it is mild, moderate, severe. Are there any associated complications? Many times we have seen that mitral stenosis is reported, but the other cardiac lesions, other valves are not seen. So it is important that we should also look at them. We can look at the chamber size, the pulmonary arterial pressures, and what to do next. What is the management strategy? How whether the patient needs any intervention, whether he needs is the valve pliable for BMV, needs a MVR, and now there are lot of advances which has come up into the approach. All these things are needed in a comprehensive echo assessment of mitral stenosis. Now, clinically, a stenotic lesion, as definition, should have thickening. There can be calcification, and it's very important that you identify a restricted opening and also the doming of cusp. This is the pathognomic of any stenotic lesions. And when we put gradients, when we put colors and identify, look at the gradients, the gradients should be increased. There should be a reduced valve orifice, and over a progression of time, when we follow these patients, as the valve narrows, the gradients increase. And remember that all stenotic lesions are dependent on both preload and afterload. So emphasizing that whenever we report any case, and heart rate should be there, so an ECG should be there, and if possible, you should have a blood pressure monitoring, blood pressure record just at the time of doing an echo. So a normal mitral valve orifice as defined is around 5 to 6 centimeters square, and this is mild moderate. And the recent severe mitral stenosis has been changed by the AHA guidelines, and it has come to around less than 1.5. And with exertion, if the patient is symptomatic, it is defined as severe. And critical mitral stenosis is any mitral valve area of less than 1 centimeter square. And a gradient wise, if the gradient of mean gradient, very important, is critical mitral stenosis. Now, remember that this is definition for rheumatic mitral stenosis. And there is something different about degenerative mitral stenosis, which I'm going to tell you also. And the gradients correlate with the heart rate and the blood pressure. So mentioning it is always mandatory in every reporting of case. So as I said, mitral stenosis is rheumatic, most common, everybody does it. Degenerative, very important because we have already started looking at a lot of degenerative mitral stenosis as the aging is advancing and we get mitral annular calcification. And there is something called congenital mitral stenosis, which is always at from birth. Now, whenever first we discuss about rheumatic, valvular involvement in rheumatic, isolated mitral valve is the most common, but you can also have involvement of other valves associated with them. And so it is mandatory to look at all the valves whenever you are reporting mitral stenosis. So this is a three-dimensional picture, and don't get this that I'm just jumping on 3D, but I'm just want to show you that the mitral valve and assessment is not only the valve; it has a lot of structures. So we have to understand that the mitral valve is a apparatus. So you have anterior mitral leaflet, you have posterior mitral leaflet, we have the chordae, and we have the papillary muscles through which they are integrated to the muscles, the left ventricle. So whenever we are mentioning at the mitral valve apparatus, we have to look at all these structures so that we get a comprehensive assessment of the mitral valve. So this is how we look at. This is a true specimen of the anterior and the mitral leaflet, and there is A1, A2, A3, P1, P2, P3. Importance surely comes in mitral regurgitation, but we will not be discussing that here in mitral stenosis. So mitral stenosis predominantly is rheumatic, where there is leaflet thickening beginning at the edges of the leaflets. There is a fusion of the commissures. Every word is important. Commissural fusion is the key of rheumatic mitral stenosis, which causes significant narrowing of the orifice, and there is a involvement of this subvalvular apparatus. This is the most common thing of rheumatic, but you can also have a non-rheumatic component, which is nothing but a degenerative mitral stenosis, where you have annular calcification, which can also cause restricted motion of the mitral valve leaflet. And 2D echo and Doppler imaging is an important thing in quantifying. And let me tell you that we also should also look at the associate structures like the left ventricle, and we have two-dimensional speckle tracking imaging to quantify what is the LV function. Now, why I'm telling, I will come in the subsequent images. So now this is the ACC AHA guidelines, which have come up recently, telling the advantages of echo. As you know, the 2D and 3D is portable, available everywhere. You can quantify, you can look at the left ventricle and the left atrium. And it is very important that how frequently you should do an echo in mitral stenosis. So if if your mitral valve area is more than 1.5, the guidelines in 2014 says that if it is a progressive stage B disease, then you can do an echo every 3 to 5 years. But if the mitral valve area is less than 1.5, you should, and if the patient is severe, you can do it every yearly. But if it is mitral valve area is less than 1, then I think this patient immediately goes for some kind of intervention. So remember, we have to remember that how frequently, when do you want to call the patient next? If the patient is more than 1.5, it is every second or every third year onwards. So this is assessment of mitral stenosis. So this I'm starting with now cases. A lot of cases are going to be there. So this is a classical mitral stenosis where we start with a parasternal long axis. And if you see that this is a picture of a patient whose mitral valve area by planimetry was zero point 0.7, and he was subjected to a PTMC, and his post BMB planimetric size was 1.4. So let me highlight that this is the anterior mitral leaflet, this is the posterior mitral leaflet, and you can see a doming, a classical hockey stick appearance. A rheumatic process involves the tip, and you get a subvalvular thickening. So this is the left ventricle, and you can see the subvalves are thickened in rheumatic valve. And in this short axis view, parasternal short axis view, these are the commissures. So commissural fusion is the key of mitral stenosis. So you have to document, you have to demonstrate, and on PTMC, the interventionist is always happy if he doesn't find a commissural calcification. As you can see, the valve has been opened, and there is the medial commissures have been opened up on this side. So these are the two important things which should be reported in patients of pre-BNV whenever you are sending this patient for any kind of intervention. Now, a diagnosis and follow-up, the same guidelines, the recommendations wise, they have shown that it is class 1B, that transthoracic echo should be performed. But if you are suspecting any clot, or if you want to evaluate this a presence of a mitral regurgitation, then you should subject this patient for TE, again a class 1B indication. And very important that if as they have defined that if the valve area is less than 1.5, then you should stress on doing an exercise testing and looking at post-exercise gradients in these patients. And these recommendations have been recently come up last 5 years in diagnosing and detecting early cases of severe mitral stenosis. Now, these are more recommendations that PTMC should be recommended in all symptomatic patients less than 1.5, as we have suggested. And if the patient is getting any other cardiac surgery but has a severe mitral stenosis, his mitral valve should also be targeted in such a case, again a class 1C indication. So point is, it is 1.5 is the key. Now, we are talking of only rheumatic mitral stenosis because degenerative mitral stenosis behave very differently in cases. Now, a success of PTMC is given by the Wilkinson score we are all aware of. The scoring is divided as 1 as mild and 4 as severe, and looks at leaflet mobility, leaflet calcification, leaflet thickening, and subvalvular involvement. And it has been defined that any scoring of less than 8, the patients are going to do better with PTMC. But I'm sure a lot of intervention cardiologists do even at 9 or 10. But of course, if you have calcification presence, then the things response are not that much. Now, interestingly, there was an article and which came in circulation in 2013, which looked at two important points apart from the commercial or the Wilkinson's criteria. And what they did, they apart from the mitral valve area of less than 1 centimeter square, they looked at the maximal leaflet displacement. As you can see, if the leaflet displacement is less than 12 mm, and if the commissural area ratio, which is nothing but take a short axis view and take a ratio of the area maximum divided by the area minimum. If the ratio is 1.25, then these patients are going to behave poorly. So this is one of the papers which came up, which gave something an echo score for success of PTMC, which came in circulation, and they have added two parameters. That is nothing but CA score, commissural area ratio, and leaf left displacement. If you have to remember, almost it is 12. It is 1.25 and 12. And if the displacement is mobility is less than 12 mm, or if the ratio is more, then this patients behave poorer with this kind of procedure. Now, there are a lot of patients who just come for follow-up. They are asymptomatic, rather they adjust to their symptoms, but they have pre-BMV. I mean, they have a mitral valve area of around 1.4. So as I stressed that we should give them an exercise protocol. This is one such case. This patient had a mitral valve area by planimetry of 1.4, and we did give him an exercise. So pre-BMV, it was 1.4, and you can see on exercise we could increase his heart rate, and his baseline gradients were evaluated, and as you can see, the gradient was 21/12. The patient was not complaining of any problem, but his BMV post exercise gradient increased to almost around 40/24, and the PA pressures at rest were around 30, and post exercise it went up to almost around 40. So this is such patient where you are documenting that giving a short form of exercise on a treadmill, maybe a modified Bruce protocol, you can show that with exercise, the gradients are going high with the mitral valve area 1.4. This patient, if the valve is pliable, should immediately go for a PTMC, and you can surely have a better life subsequently. Now, there has been a focus looking at the mitral valve, looking at the pliability, whether the patient can do well. But so we worked on something looking at the left ventricular function, and looking at LV function has been under investigation for decades, and as early as 1975, the first report of low LV end-diastolic volumes and low ejection fraction has been reported in patients by left heart catheterization. And has been reported, and Dr. J.C. Mohan was has been a pioneer, and he has done a lot of work. He published in 1993 that the reason for deranged LV function in mitral stenosis can be because that there is the caudal apparatus and the papillary muscles are in direct continuity with the trabeculae over the subendocardial region. And these fibers at the subendocardial region converge directly into the mitral valve annulus. And there is a fibrosis and shortening of this subvalvular apparatus in rheumatic MS, which causes changes in the longitudinal LV function and axis, and causes spherical remodeling of the LV cavity. So let me show you what I'm trying to tell really with the case. So this was a young male who was 24-year-old. As you can see, has a classical hockey stick appearance of mitral stenosis. You can see that the patient has a large LA, has atrial fibrillation, had commented had come with palpitation and PND. More images, mitral valve area by planimetry 0.97. As you can see, these are the commissures. The commissures are fused, and once we planiminate, has severe mitral stenosis. The peak gradient was 16/12 peak by mean, and the PA pressures were elevated by around 75. As you can see, his ejection fraction, this had a low ejection fraction by biplane, was around 40 in a heart rate of around 98. Of course, the patient was in atrial fibrillation, and the blood pressure was 100/70. So this patient was subjected to PTMC, and the mitral valve area improved, and the gradients decreased to mean of 6. The PA pressure came down from 70 to 35. So the important point is what happens to the LV function. What do you expect? So interestingly is that what is coming? Okay, let me just trying to gain access.
Cancel.
Okay, so as you can see, that the LV function significantly improved post BMV in this patient, and the patient has improvement. So the point is that we have seen that a lot of patients who have poor LV, maybe because of low filling, do improve their LV function by biplane Simpson if you subject this patient to PDMC. Now, so more couple of more images. As you can see, the LV function has improved. So my stress has been that what was happening, and these are a couple of more images which shows. I think it is trying to select some images.
Just
I'll
cancel it.
get it. Yeah,
Cancel.
I'm just fine. Yeah. So second case, another case, a female, again breathlessness, rheumatic mitral stenosis, heart rate of 47. Of course, must be on a beta blocker. There is no atrial fibrillation. More images, peak by mean gradient of 18/12, and mitral valve area of zero point 0.8. This is pre-BMV. A pliable valve, and 0.8, 0.9 pre-BMV levels. And if you can see on the LV function, the LV function looks pretty good. So this was on biplane Simpson, the LV ejection fraction was 55, which is pretty normal. And the patient was subjected to PTMC, and we had good mitral valve area of around 1.7, 1.8. And these are the commissures. You can see the commissures have been separated. The patient started feeling better. The mean gradient went down. But the interesting part, which interested me a lot, was what happened to the LV ejection fraction. It looked similar. Biplane Simpson took to 55. Then, but we subjected this kind of patient to strain analysis, and to our surprise, there were very significant findings. So the pre-BMV global strain was around -13, and if you remember that the strain values, normal global longitudinal strain is around -19. In this case, the pre-BMV was -13, the post BMV was -70. So there was an improvement which was not picked up by biplane Simpson. So again, Dr. Mohan had reported that there is LV dysfunction in mitral stenosis because of the restriction or tethering of the myocardium by the scarred mitral apparatus. And there is a decreased chamber loading condition, which is a chronic chamber loading condition. And there is also an interaction on the right side and left sided. It can be also be seen because of arrhythmias, which the first patient had, and there is an elevated systemic overload. And this was one of his papers where he had looked at the effect of PTMC on mitral stenosis by tissue Doppler imaging, and it came in JACE in 2004. Very important paper. Of course, Partho was one of the editors, one of the authors, and they had mentioned that there is a mobilization of mitral apparatus which leads to reversal of the increased myocardial stiffness and improved motion and function of the subvalvular structure and myocardial segments, which explained the immediate improvement on mitral annular velocities. So this was relating to the myocardial stiffness which they had proposed. Of course, at that time, there was no strain imaging. So I had the opportunity of writing an editorial to one of the papers on looking at the myocardial function. This came in cardiology in 2011, and this was looking at all the papers who had looked at looking at the LV function in mitral stenosis, and everybody had reported that mitral stenosis does cause LV dysfunction, even if the LV ejection fraction may be preserved, which can be picked up either by tissue Doppler velocities or by strain imaging. These are the recent papers, and then this excited me to do some work in which got published in JACE in 2014, and we had a subset of almost around significant 57 patients, all they all were subjected of PTMC. The LV ejection fraction was maintained, and their pre-BMV strains were around -9, and the post-BMV strains were around -13. So this got accepted in JACE, and this was the effect of PTMC on LV deformation by strain imaging. And we concluded that LV deformation is reduced in patients with severe mitral stenosis and is related to hemodynamic changes of MS. BMV results in rapid improvement. So it is important that we have been told that we should always look at the mitral valve area after 48 hours by planimetry in post BMV, but we should also look at the LV function, because there is a rapid improvement in LV function, either documented by ejection fraction or by strain analysis, which it is correlated by serial improvement in improved diastolic loading conditions. This finding suggests that reduced LV diastolic filling rather than irreversible myocardial structure abnormality contributes to predominantly reduced LV mechanical performance. So the point is, there is a myocardial factor which was proposed earlier contributing to LV dysfunction in mitral stenosis. It is unlikely, rather it is because of the volume or of the filling patterns which are affected. So the point is that even if you are seeing a patient of LV dysfunction who has severe mitral stenosis, but a pliable mitral stenosis, please subject these patients for BMV rheumatic mitral stenosis because they are going to do better if done properly, and the mitral stenosis can open up and their LV ejection fraction do fare well post BMP. So I was talking about degenerative mitral stenosis, now very important entity. So radiation-induced mitral stenosis is one of the causes. It occurs almost around 7 to 10 years after radiotherapy. The involvement is mostly the aortomitral continuity, which gets involved, gets calcified. The base, so rheumatic mitral stenosis always affects the tip, while degenerative always the calcification or the involvement starts from the base, that is the annulus, and there is absence of commissural fusion. So commissural fusion is the hallmark of rheumatic involvement. Very unlikely, very less likely to get involved in degenerative mitral stenosis. Now, this is another case. A female diabetic CABG 2 years back had breathless on exertions. 6 months, she got herself evaluated for CABG, whether her blocks were fine, had patent grafts. Her creatinine was around 1.5. So, as you can see, this is an apical three-chamber view, and this is the classical calcium in the posterior mitral leaflet. The anterior mitral leaflet is pretty okay. So, this is what we are talking. This is absolutely immobile posterior mitral leaflet, a classical condition called MAC, mitral annular calcification. And if you put colors, this will have higher gradients. So these are the colors. These patients can have mitral regurgitation, but can also have increased forward flow across the images. So this is what I'm trying to tell you. Involvement of posterior commissure, also a little bit of anterior commissure. This is degenerative mitral stenosis. These are the gradients in this patient. Now, couple of images more. This is another patient where in two-chamber view, you can see both the anterior mitral leaflet and the posterior mitral leaflet involved by degenerative mitral stenosis. So whenever we make these patients exercise, they can have a high gradient, and you can see a tachycardia increases the gradient. The important thing is these patients get symptomatic even if the gradients are slightly higher. It's 8, 9, 10 mm in mean can make these patients symptomatic. So it's very important to differentiate between a rheumatic mitral stenosis and a degenerative mitral stenosis. Commissural fusion is a hallmark for rheumatic. The bases are involved in degenerative. There is annular involvement in degenerative. Aortomitral calcification is mostly seen in degenerative. Resting gradients are relatively higher in rheumatic, while relatively lower in degenerative. The patient gets symptomatic earlier. BMV is possible in rheumatic, should never be tried in degenerative, and there is comorbid conditions like diabetes, hypertension, a lot of things. So diastolic problem is an issue in degenerative. Rheumatic, we should never consider this. So a recent paper last week came in JAC. This is from the Mayo Group. Dr. Pelika was one of the authors, and they have tried to look at all the cases of isolated severe calcific mitral stenosis. And these are all degenerative patients over a period of almost around 14 years, where they took around 491 patients. And the important thing is that isolated severe calcific MS are symptomatic at baseline. So very important that we should identify this group of patients. They are mostly symptomatic. They have high burden of comorbidities like diabetes, post radiation, hypertension, obesities. 1 year survival is around 72% if this patient doesn't go any intervention. And this patient can, the all cause mortality are transmitral gradient of only 8. If the transmitral gradient are more than 8, if the LV ejection fraction is low, if their right systolic pressure is around 50, and if they have atrial fibrillation. All these 4 factors are associated with all-cause mortality higher in this group of patients. Very seminal paper which has come up last week in JAC, and I had the honor of reviewing it and also writing editorial. And Dr. J.C. Mohan helped me with writing editorial which came up last week in JAC on this. So we labeled as calcific mitral stenosis, echoes of aging, a new entity. We were looking at rheumatic, we still look at rheumatic, but my point is that everybody should start looking at degenerative mitral stenosis. And we reported that the first case of MAC has been reported 4,000 years back in an Egyptian woman. So it is there. The only point is we are not seeing it. We have to start identifying it. Orifice in MAC is tubular, while rheumatic, the orifice of mitral valve is not tubular. The pressure half time is unreliable in degenerative mitral stenosis. You cannot do it because it generally overestimates the effective orifice area due to reduced net atrioventricular compliance. So in this patients, in this group of patients who are elderly, there is a reduced atrioventricular compliance, which may not make the pressure half time reliable. So a continuity equation is should be used. And the management strategy in calcific mitral stenosis is challenging. You cannot subject these patients to BMV. MVRs are difficult because you can have a caseous material. So the only way, there is a comment from Valentine Fuster in JACC, and they have also presented one series of patients who have undergone a trans mitral mitral valve replacement, and it has showed very encouraging results. But we need more studies, we need more longitudinal studies to understand this degenerative mitral stenosis. So mitral stenosis is not only rheumatic, it is degenerative also. And there is something very important, different spectrum I'm trying to show you is about looking at the vortices, looking at the flow dynamics in LV function. And Partho has some work on this, which is more than the myocardial factor in mitral stenosis. And the interest has started because in post BMV, the LV endosteric volume is unchanged. LV diastolic filling characterized by intracavity vortex formation enhances the flow redirection from mitral inflow to LV outflow. So normally the vortices go from mitral inflow to LV outflow, which gets hampered in mitral stenosis. So what I'm trying to show you is something very early images. So if you can see that this is the left atrium, this is the left ventricle, and this is the aorta, and these are the vortices which are happening regularly, normally in a normal individual. But this gets hampered in a patient of mitral stenosis, irrespective of rheumatic or degenerative. There are changes in the flow dynamics. And the proposed thing which we have started looking at, that in mitral stenosis, there is an increased transmitral jet velocity, which causes alteration in the vortex ring formation, and the mitral annulus recoil forces gets accumulated, which causes inadequate priming of the myocytes and lower LV longitudinal shortening during systoles, and which causes, when you subject these patients to BMV, causes an improvement in vortices and resolves the myocardial contractile. This is a hypothesis. We need to work on it, and we'll show maybe in future. So let me conclude. I think echo is an important tool in evaluation of mitral stenosis. Exercise should be remembered. Exercise can unmask the severity of mitral stenosis. LV dysfunction in mitral stenosis is common, but it is reversible. If we relieve the mitral obstruction, it reverses pretty good, very fast, acutely, because of the changes in flow dynamics. And remember, not all mitral stenosis is rheumatic. We should also be aware of a condition called degenerative mitral stenosis. Thank you, Vinayak. I'm ready for any questions.
Thank you so much, Shantanu. An excellent lecture. Really enjoyed it. Especially, I think you've touched upon the latest in this field as well. And I think, Mahesh, do we have questions? I think we'll take up questions. We have enough time. Dr. Shantanu has finished the talk in about 40 minutes.
40 minutes, yeah.
We have enough time at our hands to actually address a lot of questions. In the meanwhile, I just want to, you touched upon degenerative mitral stenosis. I think it's a evolving field. A lot of controversies, etc. there. So what I want to tell the audience is that most of the parameters, whether it is the gold standard for mitral stenosis assessment severity-wise is planimetry, which is very difficult because you have the maximum calcium deposition is actually at the base of the valve in mitral annular calcification or degenerative MAC, and hence it is not at the tips as in rheumatic mitral stenosis. So all the parameters which have yet been validated, like pressure half time of 220 by pressure half time, or even to be reliably detect, planimetry in a degenerative mitral stenosis, it's going to be difficult. And most of the parameters that we take, even the gradients, because the MAC tends to occur in mostly women, elderly individual. In fact, if you look at the data, in more than 80 years of Euro Heart Survey, they found that anybody who was, say, more than 50 years, they had about 10 to 15% MAC. And by the time they reached 80 years, almost 60% of the people will have MAC. So it is rampant, more in women, more in CKD, even in a young age group. So even continuity equation, most of these patients will have mitral regurgitation. So when you have MR and AR, so you cannot use continuity equation in MS severity assessment. So it is very difficult. The gradients will vary because you have diastolic dysfunction. LVDP is usually high in them. So the gradients will be low, and you would underestimate the severity of MS in these cases. The major problem with MAC is that you have two options. Either you do surgery in them or you do TMVR. Now, the two basic registries were MAC Global Registry and the TMVR Multicentric Registry. Both have shown very high mortality at 1 year of almost 55 to 65% at 1 year after TMVR. So even TMVR is not really, as of now, has not been validated as a treatment modality. And we know that the surgical outcome in these patients with MVR is also not very good. So I think we started getting comments and questions. So there is one question is on the net AV compliance and importance in daily practice. So, how is the net AV compliance important in these patients of mitral stenosis? Like the way I mentioned in MAC. So would you like to comment on that?
Yeah, so I think this is nothing but the diastology. So as we said that as we grow old, as we have degenerative involvement of the mitral valve, there's a lot of changes which occurs in the atrioventricular. So a lot of changes occurs in the atrioventricular filling. So diastology is a problem. The compliance is reduced. So it's all about it affects the assessment of the true gradients in this patient. That's why if you see that patients are symptomatic in lower gradient. If you see a rheumatic patient, even if you have a gradient of mean of around 12 and heart rate, let's say around 80, he will be less symptomatic versus in an elderly patient who has a gradient of 10, heart rate of 80. The symptom will be more in patient who is elderly because they have more comorbid conditions. So diabetes, renal insufficiencies, hypertensions, all this causes changes in the myocardial structure, both of the left atrium and also of the left ventricle. And this adds to the performance of this patient. So what is net AV compliance? Is nothing but an integration of the left atrial function, left ventricular function, and the flow across between them, which gets hampered as the patient ages. Did I make it more complicated?
No,
Or
that's
simple?
fine.
I don't know. Yeah.
I think basically you said it very well. We can give them examples of multivalvular heart disease when you have aortic valve AS or AR. And in these patients, like for example, in aortic stenosis, the LVDP will be high, the gradients will be low, and you may underestimate the severity because of the associated valvular lesion. So in a lot of these cases, we can actually go by planimetry. And a word about 3D, I would like to mention that 3D echo has come up in a big way in mitral stenosis. There have been recent papers with which they have shown that if you take a 3D zoom and you planimeter it, from the LV side at the tip, that correlates very well with the mitral valve area which you determined by pressure half-time or other methods. Now, we know that 3D usually underestimates the mitral valve area as compared to 2D. But recently, you've also seen some of the reports, small studies with CMR being used to assess the severity of MS. And that correlates very well with the 3D mitral valve area by planimetry. Okay, I'll move on
Actually,
to the next
I
question.
didn't touch upon the 3D part because of 40 minutes. I wanted to push it at 40 minutes. I wanted to stress more on the degenerative mitral stenosis. So people should start looking at it. It can be identified, and I mean they should see more. That's the reason, because 3D is a phenomenal tool, and the way you cut it, you can get at the tip and get good mitral valve area. Yes.
Right. So I have another question by Dr. Atul, where he's asking, what are the parameters for exercise stress echo and how much increase in gradients is significant? You showed 2-3 cases where after the exercise, the gradient just shot up. So
Yeah.
any word on that?
Yeah, so exercise stress test for rheumatic mitral stenosis should be done in any patient whose mitral valve area is less than 1.5 and the patient tells that I'm not symptomatic. So you document that the patient becomes symptomatic. How do you do it? So the way we do it, you can go on a treadmill or a 6-minute walk test. So on a treadmill, I generally use a modified Bruce protocol because directly going for a Bruce protocol, the patient can be symptomatic very fast. So even if you get a modified Bruce protocol and document any increment in the gradient, a mean gradient, and the symptomatology and at the PA pressures. If these three things are documented, then you can subject these patients for BMV. While in degenerative mitral stenosis, well, a very less data is available on exercise stress test. But I can, if you give me 1 minute time, I can show you a recent article which we published last month on exercise behavior of degenerative mitral stenosis, and where we have shown that if the mitral valve gradient of more than 15 mm and a PA pressure of more than 60 mm, you can quantify them as severe mitral stenosis. So by the time I can save this data on this, I mean, I have got a lot of work on this. I mean, maybe Vinayak can keep on going, and I can share one slide of mine where I can show this by the
Sure.
time we have more questions.
Okay, so I'll take another question, which is by Dr. Vadgaonkar, where he's asking your comments on low flow, low gradient rheumatic MS. So I just want to say that there was a recent article in Journal of American Heart Association in 2019, where they actually showed that the survival in these patients of low gradient, low flow MS. So you have high, most likely, most of them have underlying LV dysfunction, probably which you can pick up by LV strain, and the low flow states are there. And these patients have the poorest survival. But when you compare it with high gradient mitral stenosis, these patients have intermediate survival, and the patients who have normal flow with low gradient MS, they have the best survival. So I think you're seeing a lot of very similar to low flow, low gradient paradoxical AS. You have a similar entity with very poor survival in this group as well. Okay.
Yeah, so the point is we have to look at the LV function. It is very important. If you are documenting LV dysfunction in a case of mitral stenosis, be careful about the gradients. The gradients may not be true. So can I share the screen again?
Sure,
Just
sure.
one
Please
second.
go
Let me
ahead.
share the screen. And
Please go ahead.
this is what I was trying to tell. Okay. So this is data from International Journal of Cardiovascular Imaging, again published last month. So I contributed a little bit. So this came from Greg Pressman. He's in New York. So we subjected and looked at exercise behavior of degenerative mitral stenosis. So they were put on a modified Bruce protocol, and mitral valve gradient of more than 15 mean gradient of more than 15 and a PA pressure of more than 60. So this was important in identifying this patient, we followed them up also. So the point is, if you can identify these two things, uh, uh, and these are important things. We looked at left atrial, a lot of things work is there. So maybe you can go on this and look at exercise behavior of degenerative macular stenosis and read that article. If anybody needs it, I can share that article and we can have. So exercise behavior in MAC, it's very primitive. We have to do more studies. That's my point.
Okay.
Yeah.
So I think you've answered that. One question is, can you comment on the discrepancies in evaluation of severity and how to kind of take care of the pitfalls that occur
In mitral stenosis?
In mitral stenosis, yeah.
Yeah, I think the key is, I mean, you should always use multiple ways. On how to avoid this is look at the heart rate, look at the blood pressure, look at the planimetry area, and look at the gradients, and look at the LV function. So, and associated valves, valvular problem. Never ever just give a mitral valve area and label that this is mitral stenosis. So as we have discussed, that if there is LV dysfunction, you can have low flow, low gradient mitral valve problem. If you have associated MR, if you have associated aortic valve problem, then the gradients may change. So discrepancies are always can be seen. So a comprehensive assessment is important. A clinical judgment is important. And I'm sure the best way to planimate will be three-dimensional, where you can go at the tip and look at the mitral valve area.
Okay. I agree. I think whenever you're in doubt, there was another question. So whenever you're in doubt, I think planimetry will remain your gold standard. And one thing which I can say sometimes is the pitfalls which you get. For example, if you have associated mitral regurgitation, your pressure gradients will be very high. So you have to look at the flow. So you have to understand one thing, that if you look at the so-called Gordon formula, now, when the mitral valve area decreases below 1 centimeter square, so cardiac output divided by MVA in the Gorlin equation. So the moment you have any increase in cardiac output, the gradients will just shoot up, significantly when the area is less than 1 centimeter square. Now, suppose there is a very large, very 6 feet tall person, very large person. In that, because the cardiac output is a little more to get the tissue perfusion done, so even 1.2 centimeter square area may be significant in a larger body. So I think those are the things that you have to remember. Then sometimes you get a bimodal trace on pressure gradient, where you have the initial peak and then there is a flattening of the slope. So please do not take that peak. You have to take that slope during the pressure half time. So you have to extrapolate the flat slope of the DT, and that's where you should take the pressure half time. So those are some of the things you have to also look at. I mentioned about the associated multivalvular lesions like aortic stenosis, AR, which can cause discrepancy in gradients. So if your LVDP is high, if the patient has hypertension, these can influence the gradients, and hence there may be a discrepancy between what you're finding in pressure half time and gradient wise and planimetry. So one entity is never going to help you out. You have to look at the patient, you have to look at all the entities, and then decide upon the severity. Okay, I will take more questions here. So one question is, can you please guide us regarding calcium score and how to calculate it? I think you showed a very good slide about the commercial calcium. I think you can probably elaborate on that.
Talking about Wilkinson score, right?
Yeah, I think it probably means as part of Wilkins score. And you also showed a slide where you had taken out the ratio on the...
Yeah, so I think there are two things. It's about the pliability of the success of PTMC. So they have given, I will repeat, they have the scoring system is 1 to 4, and the one of the part is where is the calcium. So if the score system goes more than 8, I mean, we interventionists are always doing at 9, 10, 11 also. But if the score is less than 8, it's a pliable segment. But of course, there is another scoring system which has come up. It is nothing but the ratio of the long axis versus short axis, which is the commercial area ratio. And if the area ratio is more than 1.25, and also the displacement of the mitral valve in diastole, if the displacement is less than 12, then the success of PTMC change. Was one major article which came up in circulation, which had shown this thing. But I think it is the interventionist assessment about the pliability. But the point is, if there is commissural calcification, both the commissural calcified, they are going to do very poorly. So commissural fusion, but absence of calcium, send them for a PTMC, even if the LV function is poorer. They open. So the key is in the PTMC opens up the commissures. But if and put up, you can get commissural MR. But if you have a central MR, then we have problems.
Okay, there is another question by Dr. Vadgaonkar about mitral valve resistance in MS. And I think we don't really use this. Mitral valve resistance is basically your mitral transmitral pressure gradient divided by the aortic flow, LVOT VTI divided by diastolic filling time. That's basically mitral valve resistance. And there are a few articles where they've shown that it could be a very good parameter in selected cases where to actually look at the stenosis severity and can look at some patients who may be symptomatic even in that moderate mitral stenosis subset. But I think most of us are not really using that entity, but just for the knowledge sake, I guess one can touch upon it. Okay. Then another is by Dr. Parashar, the low gradient severe MS can be associated with severe TS and TR. And CHF and other low cardiac output states and probably bradycardia can also, contribute. That's a fair comment. I agree
That's
with
very,
that.
very important and valid point. And I think it's about looking at the LV function. You can get changes in the gradients. And as Dr. Parashar rightly noticed, that we should always look at the other valves. Just looking at the mitral valve and the aortic valve is not sufficient. Tricuspid valve involvement, looking at tricuspid regurgitation, you should also look at whether it is an organic regurgitation associated with organic stenosis or it is only a functional regurgitation. You should always looking at the tricuspid annular diameter, and because whenever if this patient is going for a surgery, they generally land up in mitral valve replacement with tricuspid annuloplasty, provided the tricuspid valve involvement is not organic. Yes, he's right. Mitral valve involvement can be also associated with TS and TR organ. Yes.
So there is one question which is being asked, and that is, how do we, by Dr. Shatakshi, how do we categorize based on echo only without a history, whether the MS is rheumatic or degenerative in nature?
Right. So I think very important point, but I think I had a slide, but let me repeat again.
Sure.
The rheumatic involvement of mitral stenosis causes involvement to start a bit at the tip. That's why you get a hockey stick appearance. That means the base is relatively spared, while in degenerative, the base is involved first. That means the annulus is involved first. So, and the second is the gradients are predominantly higher in rheumatic. The patient may not be symptomatic, but even if it's smaller gradient, the patients are symptomatic in degenerative. The third is comorbid conditions are more seen in degenerative, unlikely in rheumatic. That means obesity, renal insufficiency. So if you are asked to get an echo of a patient who is of CKD, or a patient who has a creatinine of 2.3, whatever, and you are starting seeing higher gradients across the mitral valve, look at this MAC, look at the aortomitral continuity calcium. The bases will be involved. It's very. I mean, I think Vinayak will agree that we have started seeing a lot of them now.
Yes, of course, we have. There is another
And
question.
rheumatic response
Yeah,
well with PTMC. Don't ever try PTMC in any degenerative. Can
agreed.
cause problems.
I agree with that.
Commissural involvement. Commissures in parasternal short axis view involvement is classical of rheumatic. Commissures involvement in degenerative less likely.
And as I had said earlier, that degenerative, as Dr. Shantanu also said, that it basically involves the base, and the so-called typical shortening or the subvalvular apparatus involvement is not as marked in degenerative as it is in the rheumatic. The MAC actually, or the degenerative MS, will basically involve the annulus, and there is a lot of associated aortic valve pathologies as well in these cases, where you see a lot of calcium deposition and maybe degenerative aortic stenosis as well.
So one more indication, we know the word concept called cardiac oncology. So oncology is not chemotherapy only. There is radiotherapy also. So radiotherapy, those patients who have undergone have been exposed to radiotherapy 5 years, 7 years back for any reason, mostly CA breast, can have a valvular involvement. And we have started looking at MAC in this group of patients and gradients across. So very important that we should identify degenerative mitral stenosis post radiotherapy also.
Right. There is another question is how to assess the mitral stenosis severity in the presence of atrial fibrillation, and what are the indirect markers? I think.
Yeah, I think atrial fibrillation, as you do it in ECG, take 5 beats and take a sum and an average of the gradients. That is one, and I think planimetry also helps tremendously in this group of patients. Of course, you can quantify. You have to tell that the average is of 5 beats is this much. Mention the heart rate. Look at the PA pressures and planimetry. These are the key things you should look in atrial fibrillation and associated findings of LA thrombus or something like that. It's very common.
Yeah, so there is another question by Dr. Vivek Tan where he's asking, how do you assess the severity of mitral stenosis in Guttman-Barker syndrome when you have an associated ASD?
Yeah, I think this is something has been challenging. If you ask me, the preferred is planimetry. Planimetry will not change anything. Gradients may vary because of associated left to right shunt. So the key is a good planimetry will be helpful in this group of patients.
Yeah. Okay. Let me see if we have more questions. There is one question from Dr. Devika about can you tell us something about congenital mitral stenosis?
Yeah, so congenital mitral stenosis, I mean, I have seen a few patients. If you start seeing mitral stenosis in a very young age group, of course, we have seen also rheumatic mitral stenosis in kids as young as 7 to 8 years, and I think everybody must have it. But if you have double orifice mitral stenosis, just like it is mostly congenital. There is something, I have a couple of images I didn't show, but congenital mitral stenosis is seen in younger age group. And if you have double orifice, I think I have that much experience. Vinayak, do you have anything more?
So I think when we talk about congenital MS, it is rare entity, and you can actually what you've seen is you can have hypoplasia of the mitral valve annulus, the mitral valve commissural fusion can occur, double orifice mitral valve, or parachute mitral valve is something which we have seen more as part of congenital MS. But you can actually have any, say, discrepancy of the mitral valve apparatus. So starting from your hyperplasia of the mitral valve annulus, the mitral valve commissural fusion, double orifice. I just recently seen a double orifice mitral valve, which is part of a congenital MS. So had both MSMR, severe MSMR in that case, and parachute mitral valve, where you have a single papillary muscle from where you have all the chordae coming and kind of forming an arcuate arch, kind of an arcuate appearance. And the thing which we have to remember in congenital MS is that they are, a lot of times they're associated with other very important entities like coarctation of aorta, aortic stenosis, subvalvular AS, etc. So you have what we used to call as the Schoen complex. So this is something which we should be, which we should look at whenever you come across a case of congenital MS. And this can be part of the so-called hyperplastic left heart syndrome. So I think we all have seen such cases in our
rare. I mean,
life.
Schoen's complex is
yeah.
rarer for common. Yeah.
Okay. I think that's about it. Actually, I can't see any more questions. Mahesh, do we have any more questions? Okay. So I think we've had a very good discussion, Shantanu, and I really enjoyed your talk. We've had very good questions as well. I think we've tried to cover as many questions as we can in these in this 1 hour or so. I liked especially the fact that Dr. Shantanu has given us a little more than the usual talk about MS. He's touched upon strain, he's touched upon MAC, he's, we've discussed 3D as well. So I think we've had a fruitful 1 hour on mitral stenosis, and I thank you very much for a great presentation. And
Thank
from
you,
here, yeah. And
I think it has been a good initiative. Yeah, it is a good initiative by IAE that we continue regularly doing this. Thank you so much, IAE, and thank you, Dr. Vinayak. We had a good interaction. Whatever I could not answer, maybe you took over. Thank you so much.
It was great. Thank you so much.
Thank you. Thank you.
Bye.
Bye-bye.